Hey everyone, I'm excited to kick off the first part of a two-part series on a complex but important topic, anosognosia. It's a mouthful to say, and it's even trickier to identify and assess in the adult population. In today's episode, we're diving into practical strategies to recognize and describe the clinical features of anosognosia during assessment. Let's get into it.
Welcome to Speech Scope, a MedBridge podcast where we conquer challenging topics for the medical SLP. Our aim is to deliver actionable takeaways for clinicians like you through captivating discussions with experts in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, Sarah Baar, a clinical SLP in Michigan with over 15 years of experience. I specialize in adult neurogenic disorders and the life participation approach.
Today, I'm excited to be joined by Allison Mezo, a medical speech-language pathologist and clinical educator. She's here to discuss important considerations, strategies, and tools for assessing anosognosia after acquired brain injury. We'll be diving deeper into this topic, including recent research and actionable takeaways you can implement right away. And she's also a fellow Michigander. Welcome, Allison. I'm so happy to have you here with us today. Can you get us started by sharing a little bit more about yourself? I'd love to hear what you do in the world of speech-language pathology and how did you come to care about anosognosia?
Yes. Hey, Sarah. Thanks so much. And hey to all of our fellow Michiganders.
Woo-hoo.
Thanks for that nice introduction. Just a little bit about me. So, yes, I'm Allison. I wear a few different professional hats. Like Sarah said, I'm a medical speech pathologist. I've been working for the last 7 years at Hope Network Neuro Rehab in Kalamazoo. We see people from outpatient all the way to long term. So I kind of get to see the spectrum there, which is just wonderful. I'm also a clinical educator at Western, and I have the honor and privilege to be the coordinator of the Aphasia Communication Enhancement Program, the ACE program, which I know, Sarah, you and I both hold in such high regard.
Yes, fellow
Uh,
grad.
yep,
Very
exactly.
instrumental for life participation approach philosophy.
It is, and we'll be talking a lot about that today. And I'm also a mentor for two fantastic clinical fellows. So I have I have a lot going on right now, and it's busy, but I love it. And a little bit more about me, I also identify as a brain injury survivor. So I'm still recovering from a second concussion from last July, and I really do experience a lot of those post-concussion symptoms, headache and nausea, fatigue, dizziness. I'm recovering really well. But I just kind of always want to give that credit to concussion survivors because I know what they're going through. It's really tough. It's really
Yeah.
tough. Um, Today, though, we're talking about anosognosia, and I became interested in this topic. It's not a fascinating story, but it's really because I felt that my clinical skills were weak.
Mhm.
And I was getting new and new referrals with all these right hemisphere disorders, and I just felt I had a huge lack of confidence in how to assess and treat this population. So I love a good challenge and I love a process. So I channeled all of that energy into creating a framework for assessment for speech language pathologists to be able to kind of reference and follow that's based on the highest available research that we have.
Amazing. This is going to be such a great conversation. Before we get into our conversation, I know I need to get this word to roll off my tongue. Can we practice saying this word together?
We can. It really is that elephant in the room. It's a tough word to say. You're
And
saying it
spell, let's
perfectly,
be
Sarah.
honest.
You're doing a great job. So I break it down. Anosognosia. There's two different ways, really. I use a association strategy. My mom's name is Anne, so I start with anosognosia. We can also do anosognosia, right? We can kind
Yeah.
of get it off like that. You know, my strategy, though, is just say it confidently. Fake it till you make it. It's a hard word to say. Just say it confidently. When we think of, though, the Greek components of the word, how the word is broken down. So A means, we know that, the absence of or without,
Mhm.
right?
Yep.
Nosos means disease, and nausea means knowledge. So if we put
Mm.
that together, it literally means without knowledge of disease. So if we put
Cool.
it in our patient's perspective, they don't know they don't have knowledge of their disease.
Mm.
And I think that definition kind of really captures what our patients experience very well.
Absolutely. Okay, that was a great break it down. So we're just going to say it strong and bold,
Yes.
anosognosia. So
Yes.
let's go ahead and get on the same page, just making sure our listeners that we're all starting with the same foundation of what anosognosia is. I'm just curious, like, how is a client impacted if they have anosognosia, and why is this an important topic for clinicians to be aware of?
Yeah, exactly. Um, I'm going to first define, and then I'm going to talk about the impact, and then I'll talk about why that matters for speech therapists. Okay.
Mm.
So, anosognosia is a neurological issue. It's a neurological issue, and it's defined as the reduced capacity to identify or accurately judge one's own ability and deficits. And I'm going to say that reduced capacity again. And that phrase is very important because awareness, as we're going to learn, it fluctuates. Our patient's awareness level fluctuates based on lots of different factors, including task demand, the environment that they're in, the cognitive load, pain, all of those impact awareness. But there are some symptoms, some hallmark symptoms that I want to provide. This was an article published in 2016 by Gascoigne, and the three symptoms that
Mm.
I find really insightful to kind of help define anosognosia. Number one is an unreporting of an underreporting of symptoms. So
Yeah.
underreporting. So, for example, our patients might downplay or even fail to mention any striking impairments. So, oh, my memory is fine. I can walk just fine, even if they have a left hemiparesis, right? Things like that.
Okay.
They're going to downplay or fail to mention striking impairments. The second one is a tendency towards positive self-evaluation because, like I said, without knowledge of disease, they really believe that they are functioning just as well as before the injury.
Mm. Mhm.
And the last one is failing to notice mistakes. So again, they might make a mistake, but they genuinely don't recognize and realize when they're struggling.
Mm.
So, of course, that's a lot of language, but I want to just give a few examples of what that looks like clinically.
Yeah.
So, the number one is our patient might show very limited motivation and engagement in therapy.
Yeah.
It's the patient who says, I don't want to go to therapy. I don't know why I'm here. I don't need therapy. That is pretty common. Our patients might fail to use any compensatory strategies that we recommend, even if we've been training, right? They might genuinely not believe that they need anything.
Mm.
Or refusing or not using any assistive devices, leaving the walker to the side and then proceeding walking, things like that. So, you also then asked me why clinicians need to be aware of this.
Yeah.
There was a study done, a survey study where Ramsey and Blake, SLPs, surveyed 143 speech language pathologists to assess how well equipped they felt to diagnose and treat cognitive communication disorder following right hemisphere disorder. And I just found that article so fascinating because one of the most striking findings was that 66% of SLPs reported that they did not feel that they had adequate materials to diagnose cognitive
Mm.
communication disorder after right hemisphere disorder. So that means 2 out of every 3 of us feel like we don't have the necessary tools.
Yeah.
And another significant finding is that 80% of these SLPs diagnose awareness, which is what we're talking about for anosognosia, reduced awareness, that they diagnose awareness impairments along with prosody and pragmatics only through observation, right? So not that do they only feel underprepared to diagnose and treat, but then they also are diagnosing awareness impairments through observation only. And so we know observation is, of course, a very important tool in our clinical practice, but I think it really ties back to if SLPs don't know what's available, they're not going to use them. So with all of that in mind, bringing this back to why it's important is because SLPs are arguably the main leaders in assessing awareness
Yeah.
in rehab. We
Yeah.
really are. We are the leaders here. And so I think it's important for us to talk about how, where I'm coming from as a clinician to help other clinicians feel more confident in how they actually assess anosognosia to make a really good outcome-driven life
Yeah.
participation treatment plan.
Fantastic. Yeah. And just for people listening today, it's kind of nice to know, like, hey, if you have those feelings inside that you're like not feeling great about it, I mean, you're actually not alone. And the way we grow and learn is by saying, like, I need to learn more about this topic. So I'm excited to learn about these tools today. I wanted to think about, so we're kind of calling this an awareness. This is awareness, basically.
Mhm. Yep.
And that's one of our executive functions. If we look further at this topic of awareness, we can make better decisions about clients by understanding what's called the levels of awareness pyramid.
Mhm.
I know that when I first learned about the levels of awareness pyramid, this really helped conceptualize this topic in my brain. Would you mind teaching us about this today as kind of a concrete tool or way to think about this?
Yes, exactly. Yes. So we're going to first look at the levels of awareness pyramid. This was developed in 1989. But we're going to also look at a second model today that helps us understand awareness, which is called the dynamic comprehensive model of awareness. They work together really well. So
Okay.
I invite everybody listening or watching to picture a pyramid or a triangle in your mind, and it's split into three sections. So at the very bottom, that is intellectual awareness. So that is the ability, that's the foundation of our awareness. That is the ability to acknowledge that a problem exists. So a person at this level may say, "Oh, I know I have memory problems. Yeah, my balance is really poor when I'm trying to get to and from the grocery store." Or I know that my speech is different, things like that.
Yeah.
The guiding question is there a problem? That's what we're trying to help our patients in treatment understand. Is there a problem? Though they might understand it, but don't yet connect it to their daily experiences, their daily life.
Mm.
So that's intellectual at the very bottom. In the middle, moving up one, emergent awareness. This is the realization. This is where our patients begin to recognize difficulties as they happen in real time.
Okay.
So your patient might say in therapy, "Oh, I forgot what I was going to just say right now. I just completely lost track." Or they might say, "I'm really getting stuck on this word. You talked to me about aphasia and I'm getting stuck on this word here." Things like that. So at this stage, our patients are connecting, why did the problem happen? So
Mm.
there's a problem and why did it happen? And this is really where self-monitoring begins to redevelop.
Okay.
And then at the top, we have anticipatory awareness. This is the highest level. This is where our patients can predict when a problem will happen and plan and pivot accordingly. So instead of just noticing the issues, they're going to use strategies to manage their issues. So if somebody has a memory impairment and they know they need to go to the grocery store, maybe before they didn't need a list, but now they do, they're going to plan ahead and make sure they have that list ready to go. So
Mm.
the guiding question becomes, what strategy should I use? Okay,
Awesome.
so that's the level of awareness pyramid. Now, but we also think about awareness with the dynamic comprehensive model.
Okay.
And this emphasizes that awareness is not static, that it shifts based on internal and external factors like memory and reasoning, actually like cognitive function, but also, as I said earlier, task demands and environment. And so they also give two other ways for us to think about awareness. One is metacognitive awareness or offline. That's our patient's ability to reflect on their condition outside of task performance. So kind of
Mm.
reflect after the task is done. And then online awareness, which is this sits between anticipatory and emergent awareness. It's adjusting for the behavior in real time, right?
Mm.
So all that to say that both models are important to help us to appreciate kind of the impact of awareness.
Yeah. And um, I'm just going to mention this is amazing info, and we will have this written down on our handout for people because they might not
Yeah.
be able to absorb this all as they're, doing their commute. I think it's super helpful to think about this because then in therapy, we're more like recognizing those, like the level that someone is performing at.
Mhm.
So if they're, not even recognizing there's a problem, then we don't have to feel like we have to work on a strategy because they're not ready for that yet.
Exactly.
Right.
Exactly.
Yeah. So just thinking about the levels of awareness where someone is functioning, really shifted what I targeted with someone in
Mhm.
rehab and just being a little bit more responsive to where they were in
Mhm.
that situation. Is there anything else that we should know about awareness that would help shape our thinking as SLPs?
Yes, I'm gonna actually add on more awareness definitions
Okay.
because we have the levels of awareness. We know it's influenced by different factors, but we also have the types of awareness. And I think specifically SLPs, I think this is where I struggled with the most. Understanding the differences between explicit awareness and implicit awareness and how that looks in therapy and how we assess for it and how we treat it too. So, let me break it down. Explicit awareness, that is the out loud kind. So our patients have to verbally acknowledge their issues, a problem.
Mm,
So this really kind of aligns with that offline or metacognitive awareness that we discussed, like reflecting on any issues that are happening.
okay.
So, for example, I lose my place when I read, or I have a left neglect, so I have to make sure that I scan, further to the left, things like that.
Yep.
But then we have implicit awareness, and this is behind the scenes. So, this is when our patients show awareness through what they do without needing to explain it. We really need both types of awareness because, and we have to assess both types too, that we'll get into more specifically pretty quick here.
Hmm.
Um, so, this matters in rehab, as I said, because a person might have explicit awareness without any implicit awareness.
Mm,
So, they might say something like, I know my memory is terrible, or I know I'm very impulsive, but yet they won't use any sort of compensatory strategy, or they might still answer a question too quickly. Things like that.
Yep. That makes sense.
Um, so when we actually layer together the levels of awareness, right? Intellectual, emergent, anticipatory, with the types of awareness, implicit and explicit, and then the factors that influence them, right? That's how we
Mm,
get a full assessment.
okay.
It's really piecing together a very complex puzzle, but it's worth it. We need to do it.
Yeah. Just so basically what I'm hearing is we shouldn't just say, self-awareness. I mean, there's more language we need to be using and describing here to really get the full picture.
Exactly. Yep.
Cool. So I thought as we walk through looking at assessment, it would be nice to have a clinical case that we could
Mhm.
use as we explain some of these concepts. So, do you mind if we develop a hypothetical but applicable case scenario and then we can use that case to get into the specifics of assessment?
Absolutely. I want to introduce everybody to James. James is in his 30s, a young male. He sustained a moderate to severe TBI following a motor vehicle accident 15 months ago. And at the time, he was a solo driver of his vehicle, collided with a tree at high speed. So, in addition to his TBI, he's also diagnosed with diffuse axonal injury and also frontotemporal damage. So, when James came to me at Hope Network, of course, his name isn't James, but when he came to me at Hope Network, he was able to get 15 hours combined, at least 15 hours of PTOT speech, therapeutic rec, social work, psychology. Um, and so we're going to be talking about James today. So when I walk through the assessment with everybody, I'm going to also give you the results of what happened with James.
Awesome.
And just a little bit of extra information. At the time, James was married with 4 school-aged children, and he was the primary earner of his household, working full-time
Yeah.
at the time of injury.
Okay. Okay, so then let's get into the assessment for anosognosia. What does the research describe just broadly?
Mhm.
What types of things are we going to be doing in assessment for this topic?
Great. So first off, I want everyone to know that our guidance comes from mostly level 3 cohort and case control studies and also level 5 expert consensus. So we're really working with some solid data here and years of clinical wisdom. So, with all the research available, like I said, I created us a model for us to think broadly and also very specifically about how we assess anosognosia. And the major resource I used here is from Dr. Blake's work on right hemisphere disorders and other leaders in neuro rehab. So,
Awesome.
broadly speaking, 3 components to accomplish in the assessment. Number 1 is a good clinical interview. Number 2 is the comparison of the patient's self-report. So what is the patient saying versus the informants? So the informants are anybody on the care team, the caregiver, spouse, residential team, other clinicians. Okay.
Yep.
That's 2. Third is the comparison of the patient's self-report, right? So what they're saying again with objective score comparisons.
Mm.
Okay. In order to get a full picture, we definitely need to make sure that we're getting some objective information. So I'm going to provide some details and considerations as well that we all need together specifically. The main concern here is it takes a long time. It's going to take a long time to work through this assessment. Too many measures we know can overwhelm our patients. So, my biggest piece of advice here is to really pace your assessment.
Mm.
And I think speaking of that, I'm going to get on a soapbox here for just a second. Collectively, as a field, let's take off the pressure of administering a standardized test on the first day. We don't have
Mm.
to do that. The first day we meet our patient, we need to make sure that we are getting on the same team, right? Developing an alliance. There's really no other way to ruin your relationship with your patient on day 1, right? If you give them a standardized assessment. But it's also important to note here that there isn't a gold standard for assessing anosognosia, right? It's
Yeah.
awareness. Awareness is so nuanced.
Yeah.
It has to be managed uniquely from person to person, and it's not all or nothing. So
Okay.
the end goal here, though, after when we combine those 3 components, the end goal is to determine their level of awareness based
Yeah.
on that pyramid discussed. Okay,
Okay.
intellectual, emergent, anticipatory. And then to also understand what factors influence their awareness and to assess their implicit and explicit awareness. Easy peasy, right?
Oh, so easy. Can I dive in and ask a question about your soapbox? I'm just would love to know some of the logistics. How long, like, do you have like an average of how long you might complete this type of assessment when you say pace the assessment?
Yes.
Like, what is
Yes.
that? I mean, just wanting your
Depend
input.
Depending on how many times per week we can see the patient and who else is on the team, because assessing anosognosia is so interprofessional. It needs to be. There is
Yeah.
no way we can do it alone as SLPs. Um, and I know though that a lot of SLPs have to get their eval done within like the day, right? Sign it by the time you leave work. In an ideal world, we would take 2 weeks to
Yeah.
really get good information about them before diagnosing with any type of anosognosia, determining the level of awareness, right? Because
Yep.
people are complex, right? We
Yeah.
want to see how they do. We want to observe. We want to get good information. But if you have to complete your assessment, right, by the time you leave work, you're going to just really write down a more of a broad eval, write down goals and make your goals to really assess their level of awareness
Yeah.
further.
Okay, that's what I was gonna
Yeah,
ask,
that's what I would
for
do.
people in those, more stringent situations, if
Mhm.
then they can just put as a goal to
Yep,
complete this more in-depth testing. I like that.
exactly. Yep.
Okay. So thank you for your kind of 3-part framework for
Mhm.
how to think broadly about this topic. And we're going to take a minute to discuss each part in more detail. So let's start with that first component you talked about, which is the clinical interview.
Mhm.
Can you talk about what kind of info are we hoping to gather here and how do we do it?
Yes. The clinical interview is where we get the patient's self report. That sets it up for the
Okay.
other 2 big areas. And
Awesome.
it's also where we establish an alliance with our patient, right? I work for you. We're on the same team here. And depending on what level of awareness, right, we're going to get varied responses. But regardless, this is where we establish trust with our patient and rapport. So we do this by an ethnographic interview. I know we did that in college, right? But let's bring that back. We need to know what they do, their activities, their values, their culture, their life, right? We need to let them know that that is important for us to know about them.
Yes.
We also use motivational interviewing techniques. We use open-ended questions about daily functioning. We ask them to reflect on past performance and present abilities. And we can do a lot of this through self-rating questionnaires and just some
Mm.
really, just thinking beforehand about, what do we want to know about this person?
Yeah.
And so some of the specific info here that we're getting is number one, our patient's perceptions of their deficits.
Yep.
So I just discussed explicit awareness, right? That requires verbal acknowledgement. This is where our patients describe their current function
Yeah.
and how they believe their condition affects them.
Yeah. So you're getting
And
some pretty clear
yeah,
examples on, okay, do you know there's a problem, like,
exactly.
or not?
Exactly. And so, like I said, I use self rating scales here because I find that it's also easy to use again later to remeasure.
Mm-hmm. Yeah.
Um, so if I'm relating this back to James, and that's what I want to do here to, help you understand like how he reported himself, he reported that everything was the same following his injury. This includes his memory, his ability to live independently, his ability to concentrate, etc. And on one of the questions on the awareness questionnaire, I'll talk about that shortly, is he thought he would do better than expected on tests that measure memory and thinking skills. So he
Mm.
actually said he thinks he will do a little bit better as compared to before his injury, right?
Wow.
And then on the same hand, maybe in a, different setting or with our OT, he might acknowledge some memory issues, but he insists that they don't impact his daily life.
Mm.
So that's the first one. Our patient's perceptions. Number two is their expectations for recovery, right? What an important question. What is your expectation for your recovery here? What's your expectation for being here with us,
Mhm.
right? We want to know. So that's just a conversation. James expected a full recovery with minimal effort. He expected that he was going to be working and driving again within a month. And he also believed that he did not need any external strategies or long term therapy. And the third one is a differential diagnosis of psychological denial. This is
Mm.
also important. Denial and anosognosia is not the same thing. So we're
Mm.
not saying he's in denial about his deficits. They can co-occur.
Mm.
And that's important to know as well. They can co-occur, but denial is a emotional coping impairment, whereas anosognosia, as I said, is that reduced awareness.
Yep.
So we of course don't diagnose denial, but we certainly need to observe it and document any signs. I'm thankful I'm able to work closely with the neuropsychologist here at Hope Network. And so I get to read their reports and kind of pick up on that. So
Yeah.
for James, he had a neuropsych evaluation done with our neuropsychology team, and they confirmed neurological anosognosia and not denial was not present with James.
Mm. Okay.
So that's the first three things we're getting just in the clinical interview.
That's
And I
great.
think that can be done on the first day.
Yep. It's nice that you have like a structured way to approach that clinical interview.
Mhm.
And I know you mentioned some tools that help you. So what tools do you use in that clinical interview?
Yeah. The awareness questionnaire is a very popular, common tool. It works by comparing how the patient rates their own abilities, and we can compare it. So there's three versions of the test. One's for the client, for the clinicians, and the caregivers.
Cool.
It does focus it focuses on explicit awareness only. So we can get information there, right? We still have to look at implicit awareness, but the AQ works very well at focusing on explicit awareness and comparing from what the patient says to what the clinicians say to what the caregivers say, right?
Mm.
Um, it highlights discrepancies, which is very important when we actually think about awareness. And anosognosia really is, our patient is saying something, but everyone else around them is saying something different, right? There's a
Yeah.
gap there.
Yep.
Another tool we have is the self awareness deficits interview, which is just what it is. It's an interview format and it looks at different areas. I like this one because OTs can use it, PTs can use it, everyone can use it because it actually asks, questions like, so for example, one of the questions is, how do people well, do they notice anything different about you since their injury? Right. And then you can make it more specific. Do they notice anything different about your memory? Do they notice anything different about your walking? Things like that.
Mm.
So it's a nice tool for understanding how our patients view themselves. And then it also asks them to set realistic goals for themselves, based on their current function. So that's also a very good tool. And
Awesome.
both are free online.
Amazing. We'll just include the links there in
Yep.
our handout.
It's in the handout. Yep.
Excellent. Okay, the second part of the assessment framework that you talked about then is comparisons of the self ratings with the informant ratings.
hmm
What are the specifics we're gathering here, and how do we do it?
Yes, this is where things get interesting because the gaps between the self report and the informant feedback tell us a lot about the patient's awareness. And so we focus on three additional key pieces in the second component. So, number one is focusing on getting those informant reports and ratings. And take your time here. I also like to help delegate, right? If I'm trying to get specific information, I might ask PT to help me out with gathering this information or the residential team. So, we need to get report from others who are around the patient regularly because James might act one way with me in my speech therapy office, but he's going to act very differently at the residential group home, right? It's going to be
Sure.
very different. So we can use the awareness questionnaire. Um, and one of the first things that I look at, especially with James, is what he was saying versus what the therapy team and the wife was saying, right? His wife and the clinicians all agreed that he needed 24/7 supervision. And James, in particular, when prompted, he would work on a task when prompted or use like his memory notebook, but he still insisted that he was perfectly independent. And actually, what's really interesting about this is because before the injury, James's wife told me that he was the guy who wrote down every workout. He wrote down everything he ate during the day. He was constantly using journals.
Wow.
Right? But then with me, he says, "Oh, I don't need anything like that." Right? So, it was just a complete change of what he used to do. So, we ended up bringing all those journals back into our office to help him, kind of reflect and use that as as a continuing to use for a strategy. It was great.
Yeah. Awesome.
Okay, and then we also are getting the functional implications and consequences. So, here we're asking the care team, the residential team, the wife, caregivers, um, what are the real world tasks and independence concerns,
Yeah.
right? This
Like
is
if
so
he
important.
says everything's going fine,
Mhm.
what are you noticing that's not going fine and just trying to get those
Exactly.
specifics? Okay.
And using real world tasks, of course, we know is so, so, so important. So I might be reading overlaps from my residential team. Okay, maybe James was able to cook, but he left the burner on, right? And the food burned. Or maybe he doesn't use his walker when he has poor balance. Um, Maybe he doesn't initiate a simple task without a lot of prompting, right? Before that was normal for him. Maybe one of our patients, or maybe one of your patients loves to read and their job was doing like a lot of like heavy reading, but now they have a left neglect, right? And so they
Mhm.
might insist their reading is fine, but their left neglect, right? They're missing half the page. So things like that, it's really important for us to document and to understand these incidents so we can really see how it's affecting their everyday life.
Yep.
Okay. And then the third one is the presence of any other phenomena. And what I mean by that is emotional changes. Is your patient showing signs of increased agitation, anxiety, impulsivity, confabulation, those things? And then we really pull in those observations from the clinical team. I would kind of just keep a note during our team meetings. With James, our residential team is there. They would tell us what he was I know how it was over the weekend, and I would get report and I'd be like, "Oh, that's interesting. He told me this or he did this in my office," right? So you're getting this information. Um, he also presented with significant confabulation. So one
Mm.
day he had a brain injury from an old football injury. The next day it was from a military injury. The next day he drove to therapy. Um, so he also presented with what's called, I might botch this, but it's called anosognosia. That's what the neuropsychologist said. And that means that he shows decreased concern about his problems.
Interesting.
Yeah. So he was a happy guy in therapy with me, but also his wife reported a lot of anger outbursts. So, right. So that gives
Mm.
us so much more information to work with.
Yeah. Wow. I've never heard of that other word.
Yeah. And now anosognosia.
All right. I like it. Okay, you are really giving us a wealth of information here, and we've covered part one, the clinical interview, part two, comparing the self ratings with informant ratings. And so part 3 of the
Mhm.
assessment is comparing those self ratings now with objective
Yes.
scores. So tell us about how you go about that part of the assessment.
Yes. This is what we're doing when we compare what our patients say they do, right, explicitly,
Yeah.
and actually how they perform in both real life tasks, and also we're getting standardized data here if we can.
Mm,
So this is really where the interprofessional team shines because we can't do it all. We have to gather objective data here and look at awareness also by modalities: motor, cognitive, language, sensory, emotional, right? We can't do all of that. We
right.
have a lot of, we overlap a lot, right? But we also have to pull in from other clinical team members to see our patients' blind spots and also to see their strengths.
Yeah.
And, just like we do in any therapy office, right? We choose the standardized test based on what we are noticing in therapy and we want to get more information on, right? So for James, I chose a cognitive assessment and I chose the R bands, which
Okay.
is just a screener for cognition. And as I want you just to remember, James told me that he thinks he would do better on tests that
Yeah.
measure thinking and memory as compared to before his injury. So I had that in my back pocket.
Yep.
And when we did the R bands, he tested in like less than the 1 percentile in the memory subtests. Okay. So there was a big discrepancy there. That it
Yep.
was huge. We also then need to think about implicit awareness through life participation through that lens. So for this, I set up a simple prediction and performance routine in a real task. I
Okay.
asked them how they're going to do, right? That's asking for explicit awareness. James says, I'm going to do great.
Yep.
And then we have them do the task, and then we observe any errors in strategy use. Are they self correcting the errors? Are they using any form of strategy? And then we're asking them afterwards to give a short rating of their task. So with James, he and I really bonded over loving a plant based diet. Like we just love talking about eating vegetables. And so to set him up for this task, I asked him, how do you think you're going to do on remembering 3 items from the grocery store? And he said, no problem. I'm going to remember them. And remember, this was the guy who wrote down everything before his injury.
Yeah.
Okay. I asked him, is there anything you need here to be successful? And he said, no, I got it. I'm going to put it right in my brain. So I provided the items: nutritional yeast, cashew yogurt, oatmeal, right? He repeated them back to me so I knew. Then I gave just a brief distractor conversation. And then I asked him again. He was unable to recall any of the items.
Mm,
And when I asked him how he thought he did, he kind of scoffed and laughed actually about it. And he attributed it to my bad memory, right? So I think that was kind of a defense mechanism coming in.
mhm.
And so in the specific task here, James didn't demonstrate any implicit awareness. And he kind of had a little bit of explicit intellectual awareness, kind of at that comment afterwards, right? But that gives us good information objectively to
Yep.
document. So then we
Yep.
can remeasure that later.
Awesome. I like that you're using a real task that someone, in theory would need to do too. I
Mhm.
think that's a really cool way to, like, a lot of people could take that and
Yeah.
individualize it for the client. And maybe that would support the client recognizing the challenges too, because, who
Yep.
cares if you can remember 3 unrelated words, right? We never have to do that in real life, but when all
Mhm.
of a sudden it's like, "Wait a sec, I'm used to remembering 3 items from
Mhm.
the grocery store,"
Mhm.
then maybe that could support them building that awareness, so
Exactly. And this
yeah,
goes back to the ethnographic interview and actually just doing a good clinical interview because
yeah,
James was the primary grocery store runner for his household too, right?
yeah,
This was his thing.
yeah, that's fantastic.
Yep.
Okay, so that was really helpful to kind of see how you do those 3 components of the
Mhm.
assessment, and they really do build on each other.
Yep.
So once you get all that information, how do you decide the level of awareness? Just to go back to our beginning
Mhm.
conversation, how do you just describe that or decide what level of awareness is James at?
Exactly. It's domain specific, right? So PT might have a different level of awareness, like on the level of awareness pyramids than OT than speech.
Mm,
But putting the whole picture together requires us to put together what our patients say about themselves, what the caregivers and clinician report, and how they actually perform on tasks
Mm.
and real world routines. Okay. So I like the awareness questionnaire is so wonderful because I will literally lay them out on my desk and highlight where the discrepancies are. Right. And so that gives me also good goal areas to address if it fits within our scope of practice.
Wow, that's awesome.
So
Yeah, so
we
you
do
make it
know that,
really tangible for the patient as
yes,
well. Yeah.
exactly. And we know that awareness shifts day to day and it's so nuanced, but when we put in the effort to do that whole evaluation, that holistic evaluation, it will give us a good idea on where to steer treatment. That's why we don't want to rush the eval.
Awesome. So, if we think about the levels of awareness pyramid that we talked about, those 3 levels, where did James end up falling?
Any guesses?
I think we're at the bottom is my guess.
Yes, he is at the intellectual awareness level in the cognitive domain. So you see how I'm specific there. In the
Yep.
cognitive domain, his language function was normal, and there was no dysphagia and no motor speech issues. Right? So he's barely at the intellectual awareness. So we are really starting there for treatment. He
Okay.
knows that there is a problem in a general sense. He knows he had a brain injury, he mentioned some memory problems, but he doesn't notice errors as they happen or plan ahead to prevent them. So
Mhm.
his explicit awareness is really surface level, and his implicit awareness only appears when he's cued.
Mm.
He will use a note and a sheet when we prompt him for it, but he won't initiate that independently. So
Okay.
going back to the pyramid, he can kind of answer, is there a problem? He can answer it broadly, but not yet functionally. So that's where we're going to start.
Awesome. That was super helpful. That feels doable. There's
Mhm.
some specific tools we have in our back pocket. I am curious in your clinical practice, who are the clients that you are like, you know what, I'm
Mhm.
going to do an anosognosia workup here? Are
Yes.
there certain conditions or patient populations or like even like those complaints that are red
Mhm.
flags? I'd love to hear your thoughts on that.
Yeah. So we're going to screen for anosognosia anytime the story does not match the function,
Okay.
right?
Yep.
So if there's a gap between what the patient is telling us and the care team is telling us, that's a red flag for us. The most common patients we have who have anosognosia typically is the right hemisphere stroke population or right hemisphere disorder. But guess what? It can happen in left hemisphere stroke, TBI. It can co-occur with aphasia. Right, so any acquired brain injury, we should actually just have on our listening ears for when the story does not match the function.
That's great. I know we could probably talk about this next question for a long time, but I just want kind of your short takeaway
Mhm.
about goal setting.
Yes.
So, how do you see the assessment results leading to goal setting? Like, once you've done the work to think
Mhm.
about what level someone's at and what type of awareness they have,
Mhm.
are there certain features that give us like something quantitative to measure or compare to over time? What's working great for you in that
Yes.
regard?
I love writing goals. I know clinicians struggle with goals, but I love writing goals. We're gonna write goals, broadly and simply, really to kind of highlight what we're doing, like in the therapy room and specifically. I'm kind of a lazy goal writer. I love writing goals, but I'm kind of lazy at it. I will use the awareness questionnaire a lot
Yeah.
to reduce the mean discrepancy. So I might write a goal like, by 8 weeks, James will reduce the mean discrepancy between his self ratings and the caregiver and clinician ratings on the awareness questionnaire by 2 points. Okay. So then I
Nice.
can remeasure. That's a very easy way to remeasure our goals. But again, implicitly, right, we need to teach them strategy use. So I'm
Mhm.
also definitely going to see where functionally they need a strategy for their implicit awareness, right, to recognize a problem is happening and fix it.
Yep.
So I'm also going to write a strategy goal. And then I also write a caregiver goal. That's also important too, because we get to do caregiver training. There are new CPT codes we can use for 30 minutes of caregiver training. So I always write a goal that I'll give, 2 or 3 30-minute training sessions to caregivers.
Oh, awesome. Fantastic.
Yep.
Okay, this has been a super fascinating conversation. I feel like we've covered so much ground. So, if we were going to talk maximum
Hmm.
impact, what would be your top 3 actionable takeaways for clinicians to put into practice when we're thinking about assessment of anosognosia?
Number one is being intentional with our language. We are no longer saying Mr. Jones is completely unaware of his deficits, right? Those blanket statements need to go out the window. We're going to shift from that kind of deficit heavy phrasing to language that's more accurate and respectful.
Mm.
So he has reduced awareness of his memory, right? He has
Mhm.
reduced awareness of how his balance is, things like that.
Yeah.
Because words shape perception,
Yeah.
both for the patient and for the therapy team. So number one is choosing language that supports collaboration with our patients and preserves their dignity.
Love it.
Number two is slowing down and being thorough with our assessment. It's complex. It's a very hard disorder to treat. We're going to use our time. We're going to pace it. We're going to look at things from different angles. The framework that I kind of built up, you can look at that to help guide you across, thinking also of the modalities, in which you're treating in. I know it can be challenging in a fast-paced hospital setting, but, I want to invite every SLP here to take that initiative, right? To be the leader here because we really are the leaders in diagnosing anosognosia. And then number three, build your assessment toolbox now, right? Download the AQ3 forms and the self-awareness deficit interview. Get your toolbox ready. Find some good handouts that you like. Familiarize yourself with them. Functional needs checklists are
Yep.
fantastic to understanding what areas need to be focused on for real life. And the more prepared you feel, the more confident you will feel in actually delivering an effective assessment.
Absolutely. That is fantastic. Thank you so much for sharing your depth of knowledge and really
Yeah,
for being the one who's like, you know what? I don't know what's going on here and I want to figure this out. Let's
yeah.
get to the bottom of this. As we wrap up our chat today, do you have any final words of wisdom or inspiration you want to leave with this audience?
Yes. If you're listening and you don't feel fully confident, I'm sure this was a lot of information for you. That's okay. I've been there. Sarah's been there. You don't have to be perfect in your assessment to answer every question to help somebody with anosognosia. What matters is that we show up, we're consistent, we provide empathy, we lean into the complexity that anosognosia is. Okay? We need to remember that resistance from our patients is not personal. It's
Yeah.
not willful refusal. It's part of the condition. And our job is not to force the awareness, but to create conditions where awareness has a chance to grow. And that starts with trust, the therapeutic alliance. We're going to approach our conversations with openness, not correction, giving them a space to feel safe in our office. Admit when we say something wrong or when we make a mistake, right?
Yeah.
And celebrate the smallest moments of insight as well. So awareness unfolds slowly, but with the right support, it can unfold. And you can be the clinician to make that happen.
Oh,
So
that's
thanks, Sarah.
beautiful. That's wonderful. That is the end of our conversation for now. And I do want to let the audience know we are not going to just leave you hanging here because even though Allison gave us a wealth of information about assessment, a lot of us might be thinking, so what do we do then in treatment for anosognosia? The
Hmm.
great news is we do have a second episode coming out on SpeechScope all about treatment for anosognosia. So please look for that as the next step. Allison Mezo, thank you so much for being here today, for sharing your insight and your clinical takeaways related to assessment in anosognosia.
Thanks, Sarah.
Thank you for tuning in to this episode of SpeechScope by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or on your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. SpeechScope also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com.